Well, yes, I really think that manual ventilation of preterm infants presents a particular challenge. I mean, we are in a phase directly after birth, after delivery, and it's really a vulnerable period. And if we over or under ventilate the baby, this may have consequences. So especially over ventilation may be a problem, lowering the CO2 to a range which means that a possible cerebral vasoconstriction reduces the perfusion of the brain, or on the other hand, an overventilation, overinflation of the lungs may impede the venous return from the brain, and this may lead to cerebral hemorrhage in the future.
In my opinion, a respiratory function monitor is helping to individualize patient care and is helping us to understand what we are doing. Because at the moment we only have parameters like heart rate or chest movement or positive inspiratory pressure, but with a respiratory function monitor we understand what tidal volume we give the patient and what we can improve during our ventilation. I also think that it's necessary to have regular trainings. So we need trainings to understand what we see on the monitor, how to interpret the monitor, or what's the best position of the monitor. It's necessary to have trainings in a simulated mannequin, but also to have clinical training with the monitor. And to have someone, a supervisor, who is telling us what we can improve with what we see on the monitor.
Yes, I think one of the challenges is that in the first minutes of life, a lot of things are going on. So the caregiver ventilate manually the baby, often think or even look on different things. So that's a challenge. And here a monitor device looking or monitoring the tidal volume may really help. Just giving an input and showing that the tidal volume is too high, maybe we're going up to 10 or even higher, and really gives an input to the caregiver to come down on the manual ventilation and to give an appropriate tidal volume.
So this is a very interesting question, and we know from previous research we've done with eye tracking to understand human behavior and visual attention that while monitors are helping us to improve our technical skills, monitors can also distract us. We don't know the cutoff for how much attention is distracting us from patient care. But we know that it is necessary to also look at the patient for a clinical judgment, but still use monitors to help us to improve our technical skills. Maybe for the future, and if there are enough providers in the room, it might be good to have a special provider that is just designated for supervising different kind of monitors, to interpret the data and to guide the trainee or the other provider with that knowledge, and therefore to help to individualize the patient care.
Yes, so I think compared to the NICU, the first few minutes are often a bit a black box, isn't it, regarding monitoring and knowing what exactly we are doing. So monitoring manually ventilation in this first few minutes may help in the future to give us information what's best for the baby, how do we care best for the long run, not just in the short terms of better oxygenation, but especially in the long term. So truly, I believe that monitoring these first few minutes may help to have more information and to improve the care for our most vulnerable patients.
So at the moment, there are not so many hospitals that are recording their ventilation quality during neonatal resuscitation, so we don't know a lot about it. There are some studies that use the respiratory function monitor, also many animal studies, but I think the more we'll use respiratory function monitors, the more we will learn about ventilation quality of different providers at different levels, and we can start to correlate it with heart rate or saturation or clinical outcomes and better understand what parameters help us to reduce patient harm, to reduce comorbidities, and in the end to increase patient safety.